Recording has started.
Well, thank you very much, everyone, for attending our weekly Innovative Discovery series. We are delighted today to have Dr. Wright from University of Delaware giving us a talk on neighborhood disadvantage and neurocognitive function. Before I introduce her, let me mention some housekeeping issues. So we will continue extending CME credits for the Tech Talks and the ID series presentations. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Lisa Maturo at Christiana Care, and her email address is lisa.m.maturo@christianacare.org. Our next ID series will be November 13th, and we'll have Dr. Greg Dobler, also from University of Delaware, who will talk about data science-driven projects in public health, including methods of green space usage, pedestrian mobility, air quality assessment. So this is going to be also very interesting. And we have a tech talk on October 1st. Dr. Rebecca Herbert from University of Pennsylvania will talk about reducing bias and error in research using EHR-derived phenotypes. So that's something that we should all attend because we work a lot on EHR, electronic health records. So again, I'm really delighted to have Dr. Wright here today. Dr. Wright is Associate Professor in the School of Nursing and Associate Dean for Diversity in the College of Health and Sciences at University of Delaware. She obtained a PhD in Neuropsychology from Howard University and did a postdoc research training in aging at Duke University. She has a long list of publications. She's currently the PI for a project funded by the Cardiovascular Covray at University of Delaware and is also PI or co-PI on several foundation grants. She's a very active teacher and mentor and has won multiple awards and honors, the last one being the E. Arthur Trabant Award for Women's Equity in 2019. So thank you so much, Dr. Wright, for coming to give us a talk today, and we look forward to your presentation.
Thank you. It's an honor to be here with you all. And today I'm going to share kind of a new idea, project, and analysis. Today, my presentation's entitled Neighborhood Disadvantage, Brain Health and Neurocognitive Function, a cross-sectional analysis of interrelations among cognitively normal older adults. Okay, so today I want to share just some background about older adults in the U.S. I'm going to start with some statistics and talk about some challenges in our country surrounding older adulthood. And then I'm going to get right into talking about Alzheimer's disease and risk and modifiable risk factors. And then I want to introduce you all to kind of a new, semi-novel measure of neighborhood disadvantage that I'm learning about, and talk to you about my objectives for this study. I'll tell you about a study that I conducted at the University of Delaware called the Healthy Heart and Mind Study. And lastly, talk to you a little bit about some preliminary analyses and conclusions related to these variables. So let's get started. Okay. All right, so if we look at U.S. population trends for older adults, we all know that the country is graying. Folks are living older. Year after year, folks are living to longer ages. If we look at the population ages 65 and older in particular, that population is projected to nearly double from 52 million back in 2018 to 95 million by 2060, making up 23% of our population. Over that same period, the share of the older adult population that's non-Hispanic white or diverse is projected, the percent of the population that's non-Hispanic white is projected to drop from 77 to 55%. And so as our population is aging, those older adults are also diversifying. If you look at this map here, you'll just kind of see the tremendous growth of older adults in our population. This represents the aging of the population from 2010 to 2019. So if you look at those medium to dark purple areas, those represent areas of our country where the growth of the population of adults 65 and older has grown 30% and higher. Those dark purple areas represent 60% of growth over the last 9 years. And if you look at Delaware, particularly southern Delaware, you'll see that we're in that 60% and higher range. So as our population is graying, this presents some unique financial challenges to our country's budget. We're expecting Social Security and Medicare to increase from 8.7% of the GDP up to 11.8% by 2050. Those older adults requiring nursing home care is expected to increase significantly by the year 2030, up to 1.9 million older adults. And if we think about Alzheimer's disease and what's really driving the need for elder care primarily, the number of older adults living with Alzheimer's disease will more than double by 2050 to about 13.8 million adults. In 2018, Alzheimer's disease cost the U.S. approximately $277 billion. And so I'm sure you all are familiar with the graying of the population, unfortunately, really driving the rate of Alzheimer's disease up and the associated expenses. Now, if we think about Alzheimer's disease and related dementias in particular, and the burden both on victims of the disease, caregivers, and even the country's economy, we really want to start to think about what are those risk factors for AD and related dementias, both biological and non-biological. So some of the culprits in terms of biological risk factors include the ApoE gene, being diabetic or having vascular disease. But when we think about those non-biological modifiable risk factors for cognitive decline and dementia, we often think of psychosocial factors such as stress and depression, and even contextual factors such as your environment, your socioeconomic status, or your education. So those psychosocial and contextual factors have really been a significant focus of cognitive aging research, particularly for social scientists like myself. And really identifying those modifiable psychosocial and contextual risk factors early in the cognitive aging trajectory, following it up with intervention, may help to reduce the development and burden of cognitive decline and dementia. So today I really want to focus on a contextual factor, neighborhood disadvantage, but I want to talk a little bit about what we know about having low SES and some of the early markers of cognitive decline. So research shows that Alzheimer's disease and related dementias disproportionately impact the economically disadvantaged. For example, your risk of developing mild cognitive impairment is almost double if you have low SES as compared to your higher SES counterparts. Low SES has been associated with greater white matter pathology, which is a strong predictor of stroke and also AD risk. And so when we think about socioeconomic status, we often think about an older adult's education, their income, perhaps their vocation, whether it was intellectually stimulating or if it was something work they did with their hands, as really being a marker or proxy of how well they're doing financially in life. In cognitive aging research, we're much less likely to think about the larger context and how that may impact someone's risk for Alzheimer's disease. And so that really brought me to this interesting variable and measure that I'll talk about in a few minutes, and that's neighborhood disadvantage, which is disadvantage at the neighborhood level that goes beyond socioeconomic status and encompasses social determinants of health, such as poverty, housing quality, and employment opportunities. So here we're going, I just want to make sure you can still see my screen. Okay.
Yes, no problem.
Okay, it went
Thank
black and I didn't, okay,
Oh.
sorry. So if we think about neighborhood disadvantage, it's really more of a macro level variable. So individual level SES has been associated with these cognitive aging risk factors. However, neighborhood disadvantage is a little different and a little unique. So when we think about neighborhood disadvantage, there's a really interesting measure. It's a relatively new tool. I think it dates back to 2014 that helps us to understand the disadvantage or the context of older adults. And this is based on a measure created by HRSA over 20 years ago, primarily for county level use. Amy Kind, who's a researcher at University of Wisconsin-Madison, refined, adapted, and validated this tool to look at census block groups. The Area Deprivation Index allows for rankings of neighborhoods by SES disadvantage in a region of interest. For example, if we wanted to look at the state level or the national level in terms of how disadvantaged an area is. And so this tool really tries to include theoretical factors such as income, education, employment, and housing quality, all at the neighborhood level. The Area Deprivation Index, which I'll refer to now as the ADI, can be used to inform health delivery and policy, especially for the most disadvantaged neighborhood groups. So let's take a look at how this works. Okay, so the ADI is a value that's based on a national percentile ranking or a decile ranking of neighborhood disadvantage at the census block level. So for every census block or census group, an ADI can be assigned based on the disadvantage in that particular area. So if you look at this map at the United States and you look at the legend there on the bottom left, you'll see, and this is broken into deciles. So often if you want to look, take a more general view of the ADI, you'll look at the decile level. So it's based on deciles where a neighborhood's disadvantage is relative to 9 other degrees of disadvantage. So if you look there, the areas in red at a decile of 10 are the most disadvantaged. At a decile of 1, you see neighborhoods that are the least disadvantaged. So if you look across the U.S., you'll see that most of the Northeast looks pretty least disadvantaged, while if you look at the Southeast, some of the Southwest, definitely through Appalachia, you'll see the most disadvantaged Americans. And so the ADI works by taking any particular zip code of interest, entering it into the online tool, which generates an ADI based on that zip code's census block. So let's look at a couple of studies that have used this tool to look at relationships between ADI and neurocognitive performance as well as brain outcomes. And both of these studies that I'm going to show you are out of Wisconsin. both of these researchers harmonized two cognitively normal groups from the Wisconsin Registry for Alzheimer's Prevention and the Wisconsin Alzheimer's Disease Research Center clinical cohort. So the important thing to know about this sample is that many of these participants had a parental history of Alzheimer's disease, which made them eligible for these studies. So if you look at these graphs, what they found was that participants in the most disadvantaged neighborhoods in Wisconsin displayed the worst performance on tests of executive function, verbal learning, and memory. So if you look at the least disadvantaged neighborhoods in blue, for verbal learning as well as delayed recall, you see better performance there. And the processing speed and the processing speed and executive function measure there are time tests. So you see the least disadvantaged folks a little bit lower, representing a quicker completion time on those tasks. So in general, they found that having a higher ADI really disadvantages you in terms of your neurocognitive performance. If we look at another author, the researcher that looked at these data, Hunt found that living in the most disadvantaged neighborhoods was associated with significantly lower cerebral volumes after controlling for maximal premorbid volume. And so if you look here at the graphs on the left, you'll see that those in the least disadvantaged neighborhoods have higher total brain tissue volumes as well as higher hippocampal volumes. And if you look at that kind of broken out by sex, what they found was that men in the most disadvantaged groups have the lowest brain volumes relative to those other groups. So here, in both of these studies, these findings suggest an association of community socioeconomic context distinct from individual level SES. So I'll pause here to mention that these studies really control for an individual level SES, things like how much education someone attained, how much income, household income they have, their vocation. And so thinking about that, it looks like there's something unique about the neighborhood level context that really may influence brain health and neurocognitive performance. So in thinking about the prior work, it's very good work. It shows that a growing body of work ties individual level SES to neurocognitive function and AD risk, but the role of neighborhood level context has not been fully explored. And those studies that have examined neighborhood disadvantage as a risk factor for AD have included participants with known hereditary risk. And if we're thinking about intervention or slowing the rate of cognitive decline, we really also want to be interested with those cognitively normal older adults without known risk factors for AD. So the objectives of this study were to examine associations between neighborhood disadvantage and neurocognitive performance in the following domains, as well as examine associations between neighborhood disadvantage and brain health as indicated by a number of brain volumes. And lastly, I examined sex as an effect modifier of these associations. So now I'm going to transition to telling you about a study I wrapped up in the spring, the Healthy Heart and Mind study. It's a 4-year cross-sectional correlational study of non-Hispanic, white, and African American older adults, 60 and older from Newcastle County, Delaware, and surrounding communities. We actually ended up with 165 participants at completion. This analysis reflects the first 136 participants. The aims of the overall study are to examine associations between subclinical CVD and cognitive function among older adults, to examine whether brain pathology mediates these associations, and lastly, to examine whether associations vary as a function of race. Okay, so I want to tell you guys about the study in depth. Our recruitment strategy was really to recruit 50% African Americans for our sample with a minimum goal of 40%. We used two versions of our recruitment flyers. Half of those flyers really targeted African Americans specifically. We went to a number of local venues, including senior centers and African American churches. We used the news journal, UD email blasts, neighborhood social media, church bulletins, and word of mouth referrals to recruit our older adults. I believe that's a church picture at the top and perhaps Newark Senior Center at the bottom. Inclusion and exclusion criteria. Our participants had to have greater than 8 years of education just to ensure that they could easily complete, not easily complete, but complete the neuropsychological measures. The exclusion criteria were pretty extensive, but not too stringent. We excluded for MRI contraindications, self-reported history of major disease, uncontrolled hypertension, type 1 diabetes or uncontrolled type 2 diabetes, severe head injury, and severe psychiatric disorder, heavy alcohol use, and so on. Importantly, we screened out those with moderate to severe depression prior to enrollment, as well as screened out those with an MMSE score less than 24 due to probable cognitive impairment. The study consisted of 2 visits. Overall, the study took about 5 hours to complete. Those are the screening measures we took at our screening visit, which is the first half of visit 1. Once participants were deemed eligible and consented, they completed a number of psychosocial and health behavior assessments listed there, as well as a demographic questionnaire. And then a number of neuropsychological measures. So we measure in our study working memory, attention and cognitive flexibility, executive function and fluency, response inhibition, immediate and delayed verbal memory, immediate and delayed visual spatial memory, as well as manual dexterity and motor speed. So it's a pretty comprehensive neuropsych battery. Visit 2 was a fasting visit for participants. They came to the STAR campus early in the morning. We do a fasting blood draw, blood pressure assessment, and vascular testing. For the subclinical CVD, part of our aims, we tested flow-mediated dilation, carotid intima media thickness, as well as carotid to femoral pulse wave velocity. The last part of visit 2 is structural brain MRI. We went over to the Center for Brain and Biomedical Imaging. And the major variables that we look at are total brain gray and white matter volumes, total frontal volumes, and total white matter lesion volumes. However, our images and our analysis really yield hundreds of regions of interest that we can look at, such as hippocampal volumes, which we included in this analysis. So by looking at individual regions or aggregating regions, we can really find out a lot about many parts of the brain and make generalizations about functions that may occur there. Okay, so in terms of our analysis, looking at ADI, neurocognitive performance, and brain outcomes, our first step was really to just run unadjusted correlations to identify neurocognitive correlates of ADI. Then we regressed significant neurocognitive correlates on ADI scores, adjusting for age, sex, education, and depression score using linear regression. Lastly, we derived and entered ADI by sex interaction terms into those models that were significant. We did a similar analysis for those brain outcomes, focused on total brain volume, total frontal lobe volume, total hippocampal volume, total white matter lesion volume, and total front white matter lesion volume. Again, running unadjusted correlation analyses, we identified any brain correlates that were significant that we then ran linear regression models to assess more fully, deriving those ADI by sex interaction terms as well. So let's take a look at the sample. Again, we had 136 participants in this particular analysis, mean age about 68. Our participants were 36% male. If you've ever done older adult research, this is a pretty good number. Women are much more likely to participate. That's probably true across all age groups. We managed to recruit about 45% African Americans, which we were really proud about. Our participants were pretty well educated. At least 47% of them were high school graduates. We had many college graduates, as well as several folks with postgraduate degrees. Body mass index was in the overweight range. Mean arterial pressure slightly elevated. On average, our participants had very low depressive symptomatology. And if we look at ADI, the ADI comes in just below 4. Okay, so let's look at that in a little bit more depth. So here's the distribution of ADI for the sample. So I've included this histogram here so you can see that average was 3.96. You can see that here in the distribution. About 55% of our participants were at or below an ADI of 3, so pretty much not disadvantaged. But 25% of the sample was above an ADI of 5, okay, which would be above kind of the median of disadvantage. If you look at the histogram, you'll see there were a number of folks who were in that 8, 9, 10 range, which would definitely represent the least disadvantaged. I'm sorry, the most disadvantaged. Okay, so looking at our correlation results, exploring neurocognitive outcomes and ADI, we had one significant finding here that showed that higher ADI was associated with poorer performance on the digit span backward, which is a task assessing working memory. If we look at correlations between those brain outcomes of interest and ADI, we found 2 negative correlations. Here we see that higher ADI, or more disadvantagedness, is associated with lower total brain volumes as well as lower total hippocampal volume. Now, when we enter those variables in particular into our regression models, two of those findings persisted for digit span backward as well as total hippocampal volume. So again, higher ADI was associated with poor working memory performance as well as lower hippocampal volume. We did not see any effect modification of sex for any of those variables. Okay, so let's talk about what our findings may mean. We didn't find a lot of correlation between ADI and neurocognitive performance and brain, but we did find some significant associations that may be worth thinking about. So our results suggest that greater neighborhood disadvantage may play a role in working memory and underlying brain structures, which are vital to quality of life in older adulthood. So working memory is really a important function. It really represents your ability to hold something in your memory but while doing something active. So there is a memory component as well as kind of an executive function or more frontal lobe component, that this is really a higher order process. And in older adulthood, when folks are maybe managing multiple appointments, multiple medications to take or things, a lot of things have to stay kind of on the desktop while other activities are occurring. And so this is something important to think about. How may neighborhood disadvantage really impact that process? Consistent with prior studies of neighborhood disadvantage, brain and cognitive function, again, working memory and hippocampal volume showed influence even among the not so disadvantaged. So perhaps some disadvantage matters. So here, in general, our sample seems pretty advantaged, but this really shows that there is some variability there. And so even in a group of folks that may be somewhat advantaged, there is potentially an influence there for those who aren't perhaps in that 1 to 3 decile in terms of ADI. Neighborhood level SES may be an important modifiable risk factor even among older adults with low risk for AD. And so we did some screening. I talked about the MMSE. We also used some of the performance on neurocognitive measures just to make sure that folks didn't meet criteria for MCI, and none of our folks did, looking at a combination of their MMSE and other neurocognitive scores. And so we're really talking about a sample of folks that potentially have a low risk for AD based on screening for some of those cardiometabolic disorders as well. But we want to think about neighborhood level SES as something that's modifiable. And so not just thinking about older adults and how they might increase their SES, but what policies might be put in place to improve their neighborhood level resources independently of their individual situations. Lastly, ADI may be a valuable tool to help assess contextual risk for AD and promote policy changes that increase the socioeconomic stability of older adults. And so this is a relatively new tool. A lot of care and work went into kind of creating something that could standardize this across the country. And so I think it's a really powerful tool for thinking about kind of those more distal factors that may influence someone's cognitive performance and their risk for AD, and thinking about, what that may mean for how policy should help to shape the environment for older adults. So in terms of the limitations of this study, it was cross-sectional, correlational, and so causality can't be determined here. The ADI and individual SES of our participants was likely more or was more advantaged than the general population of U.S. older adults. Again, when we looked at that map of the nation, in general, Delaware is pretty advantaged. But if you looked at particular parts of Delaware, you'll see there's some disadvantaged pockets. And our participants came from some of those areas, particularly in Wilmington. Lastly, the small sample size limited the complexity of our analysis. And so I'm going to look at this again in our full sample and see if I can do a little bit more in terms of looking at interaction, perhaps testing some mediating variables as well. So I want to acknowledge the funder of this work, NIGMS, and the pilot award, the COBRE Pilot Award that I got back in 2016. Importantly, the PI is David Edwards, and my research team, my postdoc Desiree, who's off in her first tenure track position this fall, and my research assistant Melanie Horning, and my project coordinator Constance Gerasimakis. And at this point, I can take any questions.
Thank you so much, Dr. Wright, for this really wonderful presentation and very, very stimulating. Any question for Dr. Wright? Well, while people are, thinking about questions, let me ask you. I have a couple of questions actually. I think you mentioned in your the methodology that you used, or the organization of the study. Did you have people come back for a scan, an MRI, but did you have multiple time points over a certain time period?
No. So this was cross-sectional. So it was just the 2 visits. Participants had to complete the study within 2 weeks. And so follow-up is still pending as I continue to apply for grant funding.
Okay. It's a very involved study, 5 hours of questionnaire. It must be hard to find people who are, who have time and can do that.
Well, the questionnaires only take about 2 hours. The rest is the vascular assessment and the MRI. And so I will say, as someone who does exclusively older adult research, most of the participants are happy to do it. And they've reached out about follow-up even in the midst of a pandemic.
Oh, that's great. Wow.
I've done some online follow-up with them this past summer, and they're eager to get back. So my RA is not eager to be 2 hours face-to-face with anyone yet, and so we're going to have to wait for a while. But they're pretty willing to help out. So it's a good population to work with.
That's great. Very impressive. So you didn't see any effect modification by race, I suppose, on your analysis?
I haven't looked at race yet. I think that'll. So as I think about working on a manuscript related to this work, I think that race is going to be an important moderator to look at.
All right. Any other questions? I guess I also have more of a comment and a question. Oh, I think Maddie has a question. Maddie, go ahead.
Thanks, Claudine. Hi, thanks for the presentation, Dr. Wright. A lot of my work at Christiana involves spatial analysis, and there's definitely a growing interest in using measures like area deprivation index to characterize the environments that our patients live in. I just wanted to ask if you could speak to any other area level measures of disadvantage, because it seems like there are many out there, and I wanted to know if you considered other measures for this study, or if the ADI presented a particular advantage that made it suitable for this research?
So I haven't really researched other measures. I do think that there are some more sensitive measures that may also capture social determinants of health. So I haven't really explored that literature as of yet. I think this presented just a practical opportunity because I had zip codes for all of my participants. Um, I also have addresses, so there may be some closer analysis that I can do, but I haven't gotten that far yet.
Thank you.
Thank you. So what I wanted to discuss is that, neighborhood. You mentioned that neighborhood disadvantage was a modifiable factor, to improve neurocognitive function. But oops, where? But it seems to me that it would need to be modified or improved much earlier in life, than when it occurs to older adults, because it seems that it's really a regression, or not a regression, but a path from probably very early in life to have issues with cognitive function in relation to neighborhood disadvantage.
Right. So there's a good body of work that looks at early life social disadvantage and whether that's predictive of stroke, AD risk. There's work that looks at kind of whether race moderates that association. And so I definitely agree, like neighborhood disadvantage, social disadvantage tends to, with little exception, be something that's a chronic state across the lifespan. And so, the term modifiable I'm using very ambitiously here because we're really talking about improving someone's lot or condition in life much earlier on. So by older adulthood, your social position, your advantage or disadvantage is pretty much fixed. And so, thinking about the kinds of policy changes that would improve conditions would really have to be applied across the lifespan. I think you're right about that.
All right. Any other questions or comments? Okay. Well, hearing none, thank you so much for this great presentation.
Thank you.
And
Have a great weekend, everyone.
you too. And we look forward to